Stephen McConnell, thank you for joining me today on the podcast. It's going to be a really great conversation, I think. You are just an expert in this field, and we've just spent the last 30 minutes getting to know each other. So let me just do a quick introduction first. Even though I have spoken about you a lot in the last few days to my clients in group, I'm sure there will be a lot of people who don't know who you are, but Stephen McConnell MSc is a lipid specialist and chief scientific officer at Help Defender, a physician recommended nutraceutical company based in Erie, Pennsylvania. He has extensive clinical experience developing successful lipid clinics, and lipid, for anyone that doesn't know, is fat, and leading a landmark outcome partnership with Blue Cross Blue Shield. He focuses on evidence-based natural approaches to cholesterol management and cardiovascular health and a lot more. But Stephen, today we're going to discuss kidneys and kidney disease because you know what? Lately we seem to be focused a lot on the gut and the liver, and people forgotten that we also have kidneys and they need just as much attention.
Yes.
So, Stephen, before we get into this, so one of your titles is lipidemiologist. And when you put that in any sort of app or Google, it'll correct you and say, this is not a real word, even though it is. Can you explain what is a lipidemiologist?
Well, Google and AI are absolutely infallible. And in fact, I met a guy, a doctor, when I was traveling down in West Virginia, and his sign out front had his name, it was osteopath at DO,
Mm,
and it said metabolic disease lipidemiology. Well, I said, well, that's what I do.
yeah.
Well, there's a very large lipid clinic at the University of Rochester Medical Center, New York, Rochester, not Mayo Clinic, New York State, Central New York State. And they call their lipid clinic the lipidemiology clinic. And I thought, well, that's what I'm doing. And I joined the society. And of course, if you want, you can train, sit and take the boarding exams and get a designation as a lipidologist. But I bought the boarding modules. I actually taught a doctor who sat for the boards and he passed. But um, they kind of shun people that don't have certain credentials. And they did have a test for pharmaceutical reps. And I said, look, I could teach a lipidologist more than I get from the boards because it doesn't have a lot of practical knowledge.
Mm,
And when I took the cardiovascular boards, when I graduated from Eastern Heart Institute, I'd spent most of my training at Columbia Presby. And I remember reading the boarding questions and I thought, there's a lot of esoteric in here.
mm,
How much of this is going to help me practically every day when I'm sitting there with a patient on the table and they're clinically dead and I'm keeping them alive and maintaining anesthesia? Practical stuff meant more. And I had a on the job trained individual who was grandfathered in because he had been doing it 20 years before me.
mm,
And he had a lot of practical knowledge. Well, they don't give you that.
mm.
I remember he said, I can tell the arterial line's properly oxygenated. And, I thought, this is a trick question and I don't know the answer. And I'm
Yeah.
thinking, well, you look over here. No, he says, no, there's no time to look at all the instrumentation. He said, he pulled out a pack of Marlboro and had the red top next to it and said, if the color's close to that and not darker, they're oxygenated. And I went, I like this guy, Bob, because he's practical. You don't have a lot of time to get cerebral with problem solving. So when I got into um, this whole arena and I realized lipidology was largely, and this is a horrible thing to say, but the National Lipid Association is a milestone. It's great. They don't have any codes that identify the specialty. So if you take the boards, it doesn't change your income. It doesn't change who insurance will allow you to see or not. You're like any other doctor. And
Mm.
of course, cardiologists and specialists get designation. These are the guys that can save the healthcare system money and a lot of people grief, but they don't compensate them. So I noticed the younger guys that have taken the exam in the last 20 years, I've been a member for 25,
Mm,
uh, don't have any practical knowledge. They still write Lipitor and Crestor, but they got these ABCLS next to the name. They're a diplomat of the American Board of Clinical Lipidology. And what good did it do them? They haven't really learned anything. They're doing things like every other doctor. That's
mm,
not what you're supposed to do. And
mm,
one of the great sins is nobody uses niacin anymore. There's a few. And the guys I respect, the ones that taught me, are older than me, won't even go to the meetings because they're kowtowing to the insurance industry, pharmaceutical industry,
mm.
and not
A
pushing
patient.
enlightened thought forward. Well,
Mm,
I bought the boarding modules. I pretty much committed them to memory, but most everything I've learned is on my own and from literature, and especially all of these older guys who are now retired or dead that took the time to show me how niacin. If you think you're a lipid specialist and you don't use niacin, I've got news for you. You're not a lipid specialist. You've ignored the single most effective medication there is, and it just happens to be the cheapest. So I'll get off my soapbox. But that kind of explains a lot of the healthcare system and how I look at it.
mhm.
Most of the evidence-based medicine that's extremely valuable is not funded by drug companies. It's natural compounds. Drug companies don't have any original imagination. Everything they come up with is based on something in nature, like
Mhm.
Ozempic and all the GLP-1s lose weight, reverse diabetes. Where do you think they got that from? All you got to do is go to PubMed, find the search word, follow it back until it just had a code name, like a Merck drug would be MK dash some number.
Mhm.
Well, then you go back another step and look in there. They saw something in nature that had a clinical benefit that was obvious. It probably been around for 1,000 years.
Like
They reverse
berberine
it
or something.
exactly.
Mhm.
Berberine is much better than metformin. It's just not absorbed very well. So you have to add on a mild insulin sensitizer, milk thistle, or anything that will modulate P glycoprotein. So the actual berberine molecule will get into the cell. You got to defeat that guardian, that barrier at the
Mhm.
cell's memory. So if you take berberine with milk thistle, man, now 50% gets in the cell instead of 3 to 5%. I actually made that mistake. I got excited. I quit taking berberine because I couldn't tolerate it. Anyway, most of the good science is largely unknown because there's no big money behind it.
Mhm.
And I love that stuff because niacin, omega 3s, berberine, like you said, uh, milk thistle, there's a lot of stuff. Cordyceps mushroom. Um, I use a lot of sodium bicarbonate, calcium carbonate. I show patients how to do their own diagnosis at home for almost free. $6 for a thermometer. How did they used to diagnose low thyroid? They didn't have a blood panel, which
You
isn't very
use
reliable.
thermometer, yeah.
Yeah, thermometer under your armpit. Don't get out of bed. Get up a few minutes early, set a kitchen timer, and write down your temperature on your armpit. Get 5 of those readings to avoid a couple outliers. 3 will be identical. If you're 97.8 or lower, the blood work doesn't mean anything because that's definitive, that's quantitative. And they usually tell me, oh, I feel cold, and everyone else has shorts and t-shirts on, and I'm wearing a sweater. I
Mhm.
get brain fog often, every day after a heavy meal. Well, body temperature is low, their metabolic rate is abnormally low, and the only way to restore that is allow the cells internally to generate enough heat. Well, you give them a thyroid supplementation, it corrects. And the
You
same
know,
thing with it.
just
Go
to
ahead.
stop
Sorry.
you there, I had like the audience can't see me, but you could see me that I had a big smile when you said that because my clients take their temperature every morning, or they're supposed to every morning.
You're
But
supposed to, yeah.
yeah, yesterday, believe it or not, I spoke to Dr. Dennis Wilson, the creator of the Wilson's temperature syndrome. And I'm like, well, I didn't know you were going to bring this up. We didn't speak about this before, so clearly we're on the same frequency. And
Oh, yeah, yeah.
Wilson's temperature syndrome is basically what you're saying, that just because the blood panels look normal,
Okay.
The
Yeah.
temperature is what you should be looking at and the symptom picture. And he's a big proponent of a lot of the herbs you mentioned too.
Yeah.
And I don't know, for some reason, a lot of the doctors I speak to, not big fans of the pharmaceutical industry.
Yeah. I think that's increasing. We're eventually going to see the majority of patients. That'll happen first. And then majority of licensed physicians abandon the current system. But that's risky if you depend on the system for your income.
Mm,
So most of my referring physicians are concierge, partial or total. A lot of them aren't even MDs and DOs. They're Dr. Heifner is a nurse practitioner, mid-level. A
mm,
lot of nutritionists, naturopaths refer to me. And like you mentioned, the original founder, if you will, the forefather on understanding thyroid disease was Broda Otto Barnes.
mhm,
And he came up with the Broda Otto Barnes basal temperature test, the BBT.
mhm,
And he pointed out the blood work isn't reliable. This is a guy that passed away 25 years ago.
mhm.
And I found an ancient TV interview, black and white,
I think
recorded.
I've seen that one. Yeah, it's on
Oh,
YouTube. Yeah.
and he doesn't get into some of the stuff like in his literature, but it's refreshing to see and hear the living, breathing person who founded this. And he just pointed out the blood work is not reliable. The basal temperature is the most reliable, quantifiable measurement.
Mhm.
And back when doctors had an hour or half an hour with a patient, that's all gone.
Yeah.
They would ask them that battery of questions. Well, I do that too, but when they got kidney disease, 75% of low thyroid, it's usually hidden thyroid.
And that was the aha moment when I heard you say that on another podcast conversation. God intervened and said, "You need to email this guy and get him on the podcast," because
Yeah.
I practice thyroid, talk about thyroid a lot, um, and that because I have a client who has kidney disease and I've worked with her for years, but she still unfortunately believes that what her doctor is saying is gospel. And I've said to her time and time again, you have all of the symptoms of hypothyroid, like her edema is prominent in her legs. I can see it.
Oh boy.
And she has the weight issues, the hair thinning, but she also has kidney disease. And when you said that, it was just like, that's it. I'm gonna, if I have to hunt this guy down, I'm gonna get him on the podcast.
Well, happy hunting. You found me.
I did.
Yeah, just don't mount my head on the wall, okay? What was I going to say?
Until it's
Yeah,
hunting season out where you are.
I sent you the slide deck, and it was modified several times because I was invited to present at the International College of Integrative Medicine. There's a million of those. There's at least 10 chapters in the US, but I knew one of the doctors who was a principal administrator. She was always skeptical of stuff I said, but she got COVID and she had acute kidney injury. So she broke down and took the niacin,
Mm.
the calcium carbonate, and the sodium bicarb, and her kidneys went back to normal. And in fact, her GFR was better than it was a year before she got COVID.
And these things are so cheap, like sodium
Oh,
bicarbonate, baking soda. Most of us have that in our
yeah.
house.
I have to be honest though. I usually don't mention it because it's the commercial side of what I do. But my business partner said, "You really need to monetize what you're doing." He said, you know, we're week to week financially here at the house." So I said, "Well, what are you proposing?" He said, "I've watched you do these kidney encounters with patients." He said, "They have to buy this bottle, this bottle, this bottle, this bottle." He said, "Have you ever thought about putting it all together in one pill?" I was like, "Oh, that would cost more."
Would it
I'm
work?
I'm an idiot when it comes to business. He goes, "Look, let them decide." He said, "Besides, ask the ones who got the 4 bottles if it would be worth $1 a day to buy one bottle."
Mm.
And I said, "You know what? Maybe I should let the patient." I'm not a businessman. I said, maybe you're right. Maybe the patient should make their mind up. Almost everybody elects to do that. And it's inappropriate, at the very least, impolite to ask somebody how good their finances are.
Mm.
But when I mentioned my fee, which isn't that much, less than $4 a day for 90 days.
Mhm.
Um, and some go to another 90 days. But if I can just tell by their initial responses, look, if that's unaffordable, you don't have to pay me right away. If you can't pay me ever, I'll do it for free. So I don't know, 10%, or I don't want to say charity cases. It's just
You want to
no,
help.
no, yeah, no fee.
Yeah.
Right there, I know they probably couldn't afford the kidney defender, which is the all-in-one capsule.
Mm.
And then we get that off the table. They're still getting the help. I'm doing the Lord's work. I just didn't make $1 off everybody that comes to me. I'm
Mhm.
not going to turn. I won't turn them away. That's immoral.
Mhm.
And once we get past that, then I can help them. But the kidney defender takes care of about 75% of the problem. But I also need to know: do you have LP-LA, like my wife Kathy Jean?
Mhm.
Do you have low thyroid? And going a little step further, has anyone actually evaluated how well you're controlling your insulin resistance? Like,
Mhm.
how much insulin sensitivity do you have left? Are you mild, moderate, or severe? So I have an email. I'll send it to you,
Mhm.
and you can use it if you want. It's very effective. It's based on a lot of literature that the A1C and the fasting don't really identify prediabetes very well. They deteriorate late. What deteriorates rapidly is right within the moment when you challenge the pancreas.
Mhm.
So if I have a big meal with some carbohydrates in there, which isn't necessarily healthy, but the carbohydrates are going to
Mhm.
prod that pancreas a lot more than the protein and the fat and the rest of the meal. Well, and I don't make a lifestyle of this. Just give me 5 readings, 5 large meals, dinner, supper, last meal of the day. And when you have that first forkful of food, have a timer set to 60 minutes. And then when it goes ping, stick your fingers. $12 for a glucometer. Every house in North America should have a glucometer
Mhm.
because we abuse carbohydrates and have for 70 years.
Mhm.
So, oh, I've been going to the gym. I'm buff. I got a 6 pack. I'm in great shape. You're still insulin resistant. You showed me a
A lot
picture
of
from
people
five.
are. Yeah.
Everybody is. I never see anybody that's normal. I had two out of 5,000. One was a Japanese PhD who was totally vegan. And the other was somebody who was raised kind of like Japanese in a culture where they ate fresh, like sushi grade fish,
Mhm.
never ate any sweets, never ate any carbs, and got a lot of vegetable protein with the fiber that goes with it. And, a lot of their animal protein was fish protein. I mean, almost like an Inuit diet, right?
Mhm.
And those people rarely have significant insulin resistance. But if you were insulin resistant, let's say from the age of 5 to the age of 30, and then suddenly you get serious about your health,
Mhm.
the body's memory of those decades when you weren't taking care of it
Still there.
persists.
Mhm.
What's that old thing from the literature? The persistence of memory, you know,
It's
your
like a
body
woman who
remembers.
never forgets.
Oh, they never forget. I say my wife will have 2 things engraved on her headstone. I was just saying, or um, she'll carry a grudge to the grave.
Yeah.
Or just she's still holding a grudge.
She's not watching this, is she?
No, she knows. She's heard me say it, and she'll go like that, because that's absolutely the truth.
Mm.
But when you do the finger stick, that's as close as you're going to get to an oral glucose tolerance test, which requires a lab order and a visit to the lab. And now you got to sit around for at least an hour waiting to get your fasting blood drawn. You're hungry and you're annoyed. You're going to be late for work. Just do it at home. There's an endocrinologist, Baginski, I believe is his last name, and he's located near the Mexican border, I think in Arizona. And most of his patients weren't well to do. They were very compromised
Mm.
socioeconomically and educational wise. I mean, some people find out they have diabetes because they're immigrants. It's even scarier today when they're informed they have to have a limb amputated.
Mm.
That's the first that got the diagnosis of diabetes. Well,
When it was too late. Yeah.
yeah, half his population comes from Indian reservations. The other half are non-white from south of the border. So what do you do if they got no money or their insurance is worthless if they have any? He said, he believed that there was a better way. So I think he got a grant to pay for the oral glucose tolerance tests.
Mm.
It was a reasonable number of people, good enough to get data. So it was like an abstract he presented. Then he ran what he called an FFTT, oral glucose tolerance test. So he gave it a different name, fast food tolerance test. And I laughed when I read the title and went, "Who is this guy? That sounds like a clever idea." So I read the thing, and the sensitivity and specificity were fabulous. He just told him, sign out a glucometer. Please bring back the glucometer. He said, but don't use up the entire supply of strips because I'd like to test more patients. So just give me 5. I think it was 5. And he gave instructions on how to capture that little drop of blood and how to put the little test strip in. And he said the correlation was fabulous. Now you know the level, mild, moderate, or severe. That's really valuable information. And you think about that non-white population, it's rampant. Kidney disease. I mean, African Americans are the worst, but Hispanic, First Nations, American Indians, North American Indians, they all have a enhanced risk as their birthright. So he was doing the Lord's work and he was being pretty clever. God came into his brain and gave him the idea. And I've been using that since that paper came out in 2005. He presented it to the American Diabetes Association. So anyway, you can determine how much risk you have for diabetes, what level of risk you're at. Plus, if you're diabetic, are you really well controlled or has somebody told you that? Check the postprandial. That's the most important thing. If that excursion is well controlled, it'll be less than 155. If you're poorly controlled, it'll be well above it. And of course, a lot of them don't have a diagnosis for insulin resistance, pre-diabetes. That's your best way of getting the diagnosis. And now it's the patient and the provider's business and nobody else's.
Yeah.
And you can act on it because I'm all about data. I want good numbers. I want reliable numbers. I don't like creatinine for GFR. It stinks. It's horrible. If you got a GFR and it looks normal, it's probably not. If your blood pressure is abnormal or you got diabetes or pre-diabetes or both, you may still have kidney disease, just your doctor is using a primitive, obsolete tool, creatinine. It's only $20 for the other blood marker, which doesn't have a significant error rate. Cystatin C, that's my world these days.
Well, yeah, we'll discuss that shortly. But before we go on, because it must be the Irish in you that you'll keep going and going and going like me.
Yeah, yeah, I'm a
Uh,
talker.
just for people who don't understand, they've heard the name or the term kidney disease. What is kidney disease? What does it mean if you have a diagnosis of kidney disease?
Well, if you're open to it, we can do another one of these down the road where they don't have to look at my sad face. I'll give you slides and I'll just
Yeah, we
talk
can
behind
do
the
that.
slides.
Yeah.
If I explained every little functional unit in the kidneys, they call nephrons or glomerulus unit,
Mm.
it kind of looks like a globe with a stem below it, kind of like a balloon.
Mm.
And all over it are vessels, blood vessels.
Mm.
And there's more to it than that.
Yeah.
But when that membrane, the balloon, starts to get damaged, certain things your body needs start to leak, like thyroid hormones, like protein, and things that aren't being filtered that should have been filtered are being retained and built up in the body, like phosphorus, like toxins, like uric acid. And you can see that on the blood work, like blood urea nitrogen, BUN. Well, that's a byproduct because protein is full of nitrogen. And when your kidneys aren't clearing it effectively, it builds up.
Mm.
Now, I don't treat the BUN directly. I do treat the phosphorus. And in dialysis, they're happy if they get you near 5.5. From what I've seen, most of them don't even know how to get it down. They're writing scripts that aren't that effective, and some of them are $1,000 a month to lower one thing, phosphorus, and there might be as many as 24 pills. Explain to me why that's good medicine. It's not. When
Mm.
you could take niacin and Tums, and for about 12 cents a day, you can get better control than $1,000 drug. But they'll never do that. It's it's not practical in their mind. Well, the thing is that not all the markers need to be treated directly. And what is effective is often largely unknown. But when that membrane starts to fail, most people have never had a urine check. They call it lowercase u, capital ACR. And that means a urine albumin creatinine ratio, ACR. That's a ratio of albumin and creatinine. Creatinine's high in the blood, it's low in the urine.
Mhm.
Well, it's because it should have been filtered and it's not. Well, if all you do is wait around for the creatinine in the blood to get elevated, you missed the albumin creatinine ratio. It was already abnormal for quite a while. That goes on every day. There's no real symptoms until late into the disease. The
Mm.
number one cause of death is a heart attack and stroke, and it usually occurs before they ever get to dialysis. And in my slide deck I sent you a little earlier,
Yeah.
there's a wagon wheel. And you want to send that to anybody, once we're done here, is curious. It expresses in a visual context what it means to have kidney disease. Well, it's like an old Conestoga wagon, wooden wagon wheel. Everybody knows what that looks like. The
Mm.
hub is kidney disease. It's not a distinct entity. It's the result of every spoke around it. And they only pay attention to two spokes. What about the acidosis? What about the thyroid? What about autoimmune? What
Mm.
about LP little a? LP little a isn't a risk factor for it. Well, it is, but it's actually causal. Well, how is that possible? Well, you got a problem with cholesterol particles, not cholesterol, the lipoproteins that carry it. There's several variety, and some are large and comparatively lower risk. Some are small and dense, insulin resistance and diabetes. Those are 2, maybe 4 times worse. Then there's LP little a. One of those is 7 times more dangerous than one of the regular lipoproteins. They call it ApoB, apolipoprotein B.
Mm.
So if that's affecting your vasculature and putting you at risk for heart attack and stroke, it's sure as hell, excuse my French, affecting your kidneys. And it does. And they're not all causal, but they talk about triglycerides. They talk about bad cholesterol, LDL. Those are BS numbers. Those aren't real numbers. That's what's in the particle, the cholesterol and the triglycerides.
Mm.
The range in those cholesterol and triglyceride numbers don't reflect the particles. A lot of doctors, especially cardiology, think, so I only need an LDL. They're nuts. They don't read anything. The thing is that the ApoB doesn't require fasting, and it can be very high, and you can have low cholesterol. The ApoB could be low, and you have high cholesterol. That means you got a very small number of cholesterol particles that are big, buoyant. They never touch the side of the artery like the dense ones do.
Mm.
And they're overloaded with cholesterol, but it's way less risk than have a bunch of little particles with a very small amount of cholesterol. Well, the cholesterol's not very high. I don't care. Your body needs that cholesterol. God made those particles to deliver it where it's needed.
Yeah.
And there's a form of infertility if a good particles are low, HDL particles. They're really ApoA1, this technical term. They deliver cholesterol selectively to steroidogenic tissues like male hormones, female hormones, the adrenals. They're starved if you don't have quality and quantity of HDL particles. But in the disease states, when the bad particles are elevated and they're out of range and they're damaged by inflammation or oxidation, you now have a fundamental problem with, hey, thank you. You have a fundamental problem with a diffusion gradient. It's
Mhm.
like they tell you in science courses in college. If I have a room full of balloons and the bathroom door is closed and there's no balloons in there, what happens when you open the door? The balloons rush in. There's too many in one room and there's next to none in the other room. They'll re-equilibrate to the same level of balloons in both rooms. That's how I explain it to a patient. Well, in your artery, if you have way too many particles, they're going to migrate underneath the lining because of the diffusion gradient. And if you have small, dense ones, the mosaic tiles, the cells that protect your artery that line it, have tiny little apertures. Well, the big ones can't get through that little aperture, but the little ones can. And they slip through even if there's no concentration gradient. And of course, the smaller, denser ones are from insulin resistant. So they're glycated. They've been exposed to too high levels of glucose in the blood. They're usually containing oxidative and inflammatory compounds. That gets underneath the arteries, and there's several steps going on there, but the fundamentals are important. You've just damaged the lining of your artery. Now, the HDL particles are so tiny they can go in there. There's roughly 30 HDL particles to one ApoB particle, and they're really small, 9 nanometers to 10 nanometers. They are easily passing through the junctions of those cells because they're even smaller than the small, dense ApoB particles. And they accumulate underneath there, but they don't stay. They go in, try to grab cholesterol. They correct some of the inflammation oxidation. They move back out, dump the garbage at the liver. They're like a waste management truck. The ApoB is like a dump truck. It's dumping garbage. HDL picks it up. It's a simplified but reasonably accurate representation. Let's talk about the wagon wheel. You can see the two things at the top they actually pay attention to, which is hypertension, blood pressure, and insulin resistance, which is not just diabetes, but prediabetes. And then phosphorus, they might pay attention to it, but usually late.
Yeah.
Normal isn't 5.5. That's a goal they usually can't even reach on dialysis. I find it easy to get the phosphorus down. I don't use the pharmaceuticals. I use natural stuff.
Do you
And
also advise your patients to look out for phosphorus in their diet?
oh God, yeah. I mean, that's job number one. But we're dealing with a whole generation of Americans, North Americans, who've been exposed to excessive carbohydrates their whole life. Are they going to lose weight? I joke. I say, I need you to run around all morning, 20 miles every day, and you're only going to eat straw and drink water the rest of your life. How does that sound to you? Well, it doesn't sound practical. That's kind of what we're asking them to do because carbohydrates are more addictive than heroin and fentanyl. That's not a misrepresentation. And the problem there is it's socially acceptable to eat carbs. It's not illegal, and they're horribly cheap and freely available. And it wasn't that way in the 40s and 30s. People were skinny. People exercised. People didn't have phones up in their face all day long. They actually got physical activity, and they didn't have highly addictive junk foods all around them in the grocery store. So, yes, like William Castelli said, guideline writers are wrong. They kept leading off with lifestyle changes, therapeutic lifestyle changes to prevent heart disease. And like he said, it doesn't get done. He says, I try to see how much mileage I can get, but at the end of the day, they have to take the therapeutics, the medications. Right in an interview, American Journal of Cardiology. I'll send you a copy. It's a brilliant interview with the most notable guy in cardiovascular medicine. He knew that trying to get them to lose weight, exercise, and eat right wasn't going to work most of the time because they'll fail. And then what do? Wag your finger at them, belittle them, and then they're going to go home and have a bad self-image and eat more carbs, comfort food. I mean, I have patients who aren't that old, maybe in their 40s, and the guy has erectile dysfunction because he's fat. He's either diabetic or close to it. And his wife doesn't feel attractive anymore because she's been doing the same thing to her body. So they can't even have physical relations. And the food's the only thing that gives them an endorphin rush. So they don't feel
And that's
inadequate.
something now they share in common, since as they can't be intimate, they can share meals together or movies, whatever. Well,
Yes.
at the very least, we can at least advise people like where is phosphorus most commonly found, pop,
Yeah.
junk food, at least
Soda
read your
pop.
labels, try minimize it as much as possible.
Right. Just remember the short prefix. It's a series of letters that the end of the long word varies, but the beginning is always the same. PHOS, PH, PHOS.
Mm.
pH, phosphatidic acid, phosphaturic acid, phosphate, phosphorus. They're all phosphorus. And it
Hmm.
doesn't matter that much if it's inorganic or organic phosphorus. They use it as the primary preservative in junk food. So you don't want to eat a lot of preserved meat. Soda pop's one of the worst. There's a ton in soda pop. Lay's potato chips. Don't sue me, Lay's. Um, it's in all the junk food. You walk up and down the aisles in a grocery store, it's hard to find anything fresh that's not completely full of phosphorus, not to mention other stuff. Well, people are going back to organic sources, grass-fed cattle for beef, much healthier than cattle that are kept in a pen all day and they're fed corn. Now they're a pre-diabetic cow. The
Well,
fat looks the
that's
same.
how we fatten our animals up, is we give it corn and grains. And
Right.
we
And
people forget we're animals too.
oh yeah, and it's the same thing happens to us. Only they don't seem to care, even be acknowledge that they've created a cow that's got marbling in the steak, but it's a different kind of fat. It's palmitic acid from the
Mhm.
abuse of the metabolism. Well, a healthy cow, like there's a beef thyroid I recommend, no prescription required. The lowest dose is 17 cents a day. It's beef thyroid from New Zealand. Well, I checked them out before I considered using it. They're grass fed, uh, free range cows. Well, that's the way they are, Mother Nature intended. They're walking around getting exercise, they're eating grass, no carbs, and the meat, the marbling looks the same, but it's stearic acid. That's actually good for you.
It's
You
so
can
good
tell when
for
you look,
you.
yeah, when you look at a lipid profile, it doesn't affect it. Now, if you're against beef, there's other sources of protein, but I don't think vegan is practical
You know what
because a lot
else
of,
is great for stearic acid? Not to interrupt, but dark
no,
chocolate. Really, really good
oh,
dark
yeah,
chocolate,
yeah,
stearic acid.
a
And you
lot of
know
good
as
stuff in
well,
there.
and so we've got beef and dark chocolate. I mean, I could happily live off that. But a lot of people don't know, and this is going down a different rabbit hole, but grass-fed beef is also lower in another molecule called deuterium, which directly, to put it like really simply, breaks your mitochondria. And the mitochondria, if they're not working properly, so like grass-fed, I think is more important than people recognize.
Right. And there's probably more to it than that, but just being aware that certain sources of food are at least somewhat, if not much more healthier than what we normally purchase every day and don't think about. Quit buying soda pop. It's okay to carbonate it, it's alkali, but it's the phosphorus and the simple sugars that are in there. Well, I'm a human being. I don't behave entirely, but Canada Dry, and it's a plug for his product positioning. They're not paying me. There's no phosphorus in it. They use a citrate as a preservative. Why doesn't everybody do that? It works. It's alkaline. It helps uh, keep this from going bad. And this is sugar free. Now, the sweetener in here isn't necessarily healthy, but you know what? It's a hell of a lot better than a Coke Classic. Way better. And you just got to read labels and understand where the poisons are and avoid them, or at least cut down. And I am not 100% compliant with a low carb diet. My wife's Sicilian, so I'm doomed to eat pasta. Besides, I've learned to like it since I got married, and she's a really good cook. So I'm probably about 8 pounds heavier than I should be. But when I look at my blood chemistry, I look like a 15-year-old athlete, at least on my lab work,
Yeah. Well,
not in the flesh.
you mentioned there, Stephen, well, we have acidosis on the wheel here, but you also mentioned pH in passing there. Let's discuss that a little bit. How does
Sure.
that affect the kidneys then?
Oh, it deteriorates every cell in the body because your body's fighting to conserve alkali to neutralize the positive protons, which are the definition of acid. So if you're not getting enough alkaline, those protons are now constantly creating damage to cells. They're impairing the function of the cells. They actually damage the groups of cells, the tissues. And in the kidney, it's murder. And how do we know there's a benefit? Well,
Hmm.
one of the first papers that pinpointed that it could be a benefit, and it showed it, was a 2-year study, stage 3 and 4 only. They didn't break apart three into 3A or 3B. It was stage 3, stage 4, 2 years long. They gave them less than 5 cents worth of sodium bicarbonate tablets, roughly 1.9 grams, just shy of 2 grams. The placebo group, of course, got a placebo. At the end of the 2 years, more than 35% were at stage 5, which is when they put you on dialysis or a transplant list.
Hmm.
And less than, I'm trying to quote this accurately, less than 5%, I think it was between 3 to 4% were at stage 5 with the sodium bicarb. It slows down the damage, it slows down the loss of function. And of course, the average idiot in medicine will confront me. So, you can't give us sodium. I said, wait a minute. I'm not talking about table salt. That's sodium chloride. Besides, they finally ferreted out what the real problem is. It's the chloride that drives hypertension and edema because it binds differently to the sodium. And now the sodium will retain fluid and affect your blood pressure. Every major study in sodium bicarb, they realized that this association was immediate. The bicarb killed the protons, corrected the acidosis, and the sodium was flushed through the kidneys even at stage 4 rapidly. So it didn't even hang around. Two different things. The chloride's a hidden hand of hypertension. There's a publication on that. That was the title. Chloride, the hidden hand of hypertension. Forget about sodium. That really isn't a problem if you don't define the type of sodium. And it's a metal salt. It's just the binding to bicarb dissociates like that, probably before you even get the bicarbonate into the body. And then, well, what about blood pressure and hypertension drugs and edema? They didn't see it. And in fact, about 15 to 20% in the two giant government studies show that the blood pressure got better. Well, how's that possible with sodium? Forget the sodium. The bicarbonate corrected the acidosis, and now the lining of the artery had improved function, and the arteries are now dilating more appropriately, maybe not normal, but better than they were. And the blood pressure came down with no change in drugs. Just the opposite what the average nephrologist tells me. That's why they don't use sodium bicarb. They're so timid, they wait till they're on dialysis and they give them 110-grain tablet. That won't fix anything. Now, there are a lot of big brains in nephrology. Most of them don't just make money, they do research.
Hmm.
And my favorite group is um, in the Baylor healthcare system in Texas. And they've defined this. The definitive marker is urine citrate, mostly used for kidney stones. But it tells you if you're acidotic. Well, if you're acidotic, you need alkali, and your body tries to conserve it, tries to hold on to it.
Yeah.
Well, there's less in the urine because it's holding on to it. So the citrate in the urine is low. Anything less than 28 is not normal. When it gets down close to 22, it's severe acidosis. Well, maybe you didn't order your urine and the doctor said no, even though I had told the patient to request it. That happens all the time. They never order what I request. And what do you have that you already have in the lab work? The CO2. The CO2 is a reasonable surrogate for the bicarbonate. As a bicarbonate, they call it EU, bicarbonatemic acidosis. What does that mean in plain English? That means normal bicarbonate, but still have acidosis.
Hmm.
How is that possible? All the alkali gets conserved and it's converted to bicarb. So it's always reasonably normal till it craps out at stage 4. Now, 86% of all stages of kidney disease are acidotic, and a doctor is looking at a bicarbonate level. Wrong thing. The CO2 is reasonably reliable, but if it's less than 28, insurance will pay for a urine citrate. You have evidence they have acidosis, now pinpoint it. And they're the same numerical ranges, less than 28 for urine citrate, less than 28 for CO2. Now you've documented to cover your butt, CYA, cover your, and now you can treat it. That's the whole point. You find it, you document it. If you don't measure it, you miss the diagnosis. Now you've got the diagnosis. Do something with it.
A
It's
lot
like
of
LP.
doctors, a lot of doctors won't even test the O2. 2
Right.
A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test the O2. 2 A lot of doctors won't even test which is bizarre because the body, like that makes zero sense. The body produces CO2 to function and stay alive. Why
Right.
why are
And
we not testing it?
well, it's sort of an interchanging acid-base balance process that goes on all the time, microseconds. Well, if you want to know where the bicarbonate's at, look at the CO2. But now you're reflecting the bicarbonate, and that can be misleading. And those guys in Texas finally came up with a metric that the urine citrate is by far the most reliable. And there's another one. There's also research uh, in clinical practice of nephrology. Dr. Raphael, he's in Utah. I believe he's in Salt Lake City. And he came up with a flow chart how to treat them based on the CO2. Well,
Mhm.
everybody can get a CO2 with a comprehensive metabolic profile. It's pennies, it's a very cheap test. And you can not only have a marker to treat, but you can maybe spot somebody who's at risk for kidney disease before they fall apart. And it's just knowing these connections with these biomarkers and putting the whole picture together, not a tiny piece, which is what goes on every day. They glance at the blood work for about a minute, talk to the patient for 5, make notes for 5, and go see the next patient. That's not medicine. That's making money for insurance companies and drug companies. Because I hate to sound cruel, but if an office is totally dependent on insurance company for their financial well-being, the insurance company is mandating the use of pharmaceuticals,
Mhm.
so they're driving the prescribing pen on the prescription,
Mhm.
and the doctor's influence over that is limited, and they know it. Most of the honest ones admit it's a horrible healthcare system. We're ranked in the 50s out of the developed nations. Canada's healthcare system is better than ours, and you're right over the border. Don't get me going on that, but with that wagon wheel, the red ones are the ones I usually don't even consider.
Mhm.
Subclinical hypothyroid, hidden what they call eubicarbonatemic acidosis, LP little a and ApoB, the bad particles, inflammation, oxidation, and then there's the more exotic stuff, but it's a good 10% of what I see when they're referred to me, which
Mhm.
are autoimmune. You got your autosomal dominant polycystic kidney disease, and a lot of them don't have autoimmune, but they got cysts. And I'm working on a protocol. I've seen some evidence that it could work, but a lot of it again is inflammation. It could be genetic or autoimmune. You never know for certain, but if they don't
Oh.
have autosomal dominant, um, I know quercetin is shown to inhibit the production of the cysts. If you overhydrate to get the solute per unit volume of the urine really low, it's real
Mhm.
dilute urine, there's an osmotic exchange that causes the cysts to retract. And they call it the vasopressin system.
Mhm.
If you manipulate that, it'll inhibit the formation of the cysts. And one of my first CKD patients had ADPKD, autosomal dominant polycystic kidney disease. And I tried to help him, but he ended up getting the transplant anyway. And the problem is, if it's genetic or something going on in the rest of your body, it's going to take down the new kidney just like it did the original kidney.
So hold on a second. I want to ask you something. So we spoke about thyroid. I had mentioned to you, you've said genetic a few times, and it was one of my questions because thyroid disease is usually passed down. It's usually more on the mother side, but boys can get it as well.
Yeah, yeah.
But I had mentioned to you one of my clients, 15 years old. He has stage 4 kidney disease, which is unfortunate. When he was diagnosed with Alport syndrome at age 2, except his mom and her mom and their sisters, like his aunts, they all have hypothyroid. I wonder if there's a connection there. I
Well,
wonder if this kid also has hypothyroid.
almost certainly because I see some bizarre stuff even before I got into kidney disease. My dad was my first case study, but um, is it a risk factor or is it causal? Well, before you
Mm.
waste time thinking about that, um, is it correctable? Well, then does it really matter? Well,
Mm.
if it was causal, like LP little a, like diabetes, like blood pressure, well, you correct that. But if it is just a risk factor, well, it's still contributing to it.
Mhm.
We don't know to what degree, but you go to the literature and try to ferret that out. And it was pretty interesting when I talked to this guy online, and he won't even give me the time of day because he's already accepted he has Alports and there's nothing you can do. He needs a transplant. He's on dialysis. I don't think he addressed the genetic component of what actually caused it
Mm.
because whatever new kidney he gets, it's going to
Be
attack that
exposed to the
kidney.
same body. It's still going
Yeah.
into the same body.
Yeah. He starts out with a healthy glomerulus membrane, but it's like a diabetic who didn't lose weight or controls blood pressure, and he doesn't look any better when he gets the transplant. It's a fool's paradise if he
Mm.
thinks that kidney's going to last any longer than the first one.
Mhm.
And I think that it might not be a cure, but if you have no symptoms and the progression is halted or at least slowed down, that's something. That's going to extend that person's life. Plus, I have a young man. He was 18 when his parents contacted me, and Dr. Mary Mignon, who's in New Orleans. I have to pronounce that correctly. No, New Orleans. I thought it was New Orleans. No, it's New Orleans. Okay.
Really?
And it's not crawdad, crayfish. It's mud bugs. You know,
Oh, get it
that's
right.
that's paradise for a foodie down there. Anyway, she refers this Cajun family to me. Really cool people. I just love them. And the son's first name is Hunter. I think that's okay to say that. And that's not even his real first name, but he had RMND1. RMND1. I didn't even know what that was. Well, he's seeing a geneticist, he's seeing a nephrologist, he's seeing like 6, 7 different doctors. She said, "Can you help him?" I said, "I can sure try." And I used the same damn cocktail, and his blood pressure came down. He actually felt better. He said, "Mom, I haven't felt this good in 5 years." Now, this is a genetic disorder. The parents both were heterozygous, and unluckily, he was homozygous.
Mm.
So his bilateral cochlear implants he got when he was a little kid,
Mm.
and his kidneys are failing. He's on a transplant, but he's skinny and muscular. He's otherwise healthy.
Mm.
Well, he wanted to be on the transplant list. He wanted new kidneys. And I said, "Hunter," I said, "your body did this to your kidneys. It's nobody's fault. You inherited this.
Mm.
But what do you suppose your body will do when I put the new kidney in?" Oh, and he went, "Oh." And I said, "Well, let's try to save the kidneys God gave you. And
Mhm.
if you have to get a transplant list or transplant someday, okay. But if we can hold on to the function you have, keep you off of dialysis, and at least delay the need for a transplant, would you rather do that?" "Oh, yeah. Yeah. I
Mm.
mean, who wants to get surgery with a transplant or
Yeah.
dialysis? I'm not
Yeah.
sure which one's worse, but
I
he
feel like
agreed.
dialysis it just takes over your life.
It does. And it usually takes over your finances in the US because you end up not getting all the bills paid for by insurance. They lose their house, they lose their savings,
Just
the
because
sick.
they want to stay alive.
Yeah, and they end up in a wheelchair, and now you've got Medicaid, and they have to send around a van to pick you up because you can't even walk. Well, the disease is half the problem. The dialysis is the other half. Yes, it may keep you alive 5 or 10 years if you're lucky, but it will ruin your cardiovascular system. It messes up your liver every time you go on treatment. And no matter how hard they try to remove all the toxins, you can't get all the toxins removed. And I've got a few people who are dialysis patients. I think I might be able to get them off dialysis, but the nephrologist has to agree with that.
Mm.
And that's they look at an empty chair and they think, "Oh, I'm losing money on that chair. I need somebody in that chair." I was trained rather superficially, but very effectively by a famous nephrologist who's retired. His big expertise was phosphorus control. and I won't name it, it wouldn't be polite, but he's a university in North Carolina. You figure it out. And he told me, Steve, he said, you care too much about the patient. I look at him like, and there's something wrong with that?
Yeah,
He
that's
said,
what
well,
we're
you have to
supposed to do.
understand. He goes, it's like a secret handshake. Like Masons, if their car breaks down, they have to hold their arm a certain way, and another Mason will stop and help.
When you
Or
know,
they have
you
the
know. Yeah.
right. Well, it's a dirty secret in nephrology, and they don't even discuss it with other doctors. Just the nephrologists know it. It's a cabal. They're more concerned about morbidity than mortality. I was confused. I mean, he's 6 foot, I'm 5'5", and I'm looking up, what do you mean? He goes, I know it's confusing. He said, when you get really sick, you're normally getting treatment at the dialysis center. He said, but they're going to transport you, an ambulance, a neighbor, a family member is going to drive you to the emergency room. Hospital, that's good news for the hospital because they can bill more than the dialysis center and they have their own dialysis machine. So they're not going to discharge you anytime soon. When they have to discharge you and the insurance payments stop, they'll send you back home and then you go back to the dialysis center. What's going on at the dialysis center while you're gone? Regulatory laws and so forth mandate they can't let anybody use your chair because you're still alive. You're coming back. So 3 days a week, which is a standard, 4 hours each of those 3 days. They're not making any money off that empty chair. But if you die, they have a line outside. Paperwork's in order. You died an hour ago. There's another guy in your chair right now.
Sinful, isn't it?
Made me want to throw up.
So
That's
we're
nephrology.
so it is sinful, but what so we're saying is that kidney disease is not necessarily genetic, but there's risk factors that are genetic that could then influence you having kidney disease.
Absolutely. Like Alports. They still don't fully understand it, but they know structurally what's going on with the pore size on the glomerulus because it's like a cellophane balloon.
Mhm.
It's so thin, it's a single cell thick membrane, and it's very vulnerable. There's actually protective arms of these projections that are made from protein. They're called podocytes. Basically, it means like foot processes. They kind of hold the pressure from damaging that membrane. It looks like a balloon. And then there's a huge network of blood vessels all over it. It kind of looks like if I took a big balloon and threw cooked spaghetti at it and it stuck to it randomly all over it. It's the blood vessels. It's really gorgeous to see artist renderings or electron microscopy of it because it's an elegant system that God came up with. Well, when those are damaged, some of them damage quickly and fail. Others are reasonably functional for a long time, but you're now shifting the workload from a normal amount of nephron units, glomeruli, to a diminishing number. And now those have to work as hard as the original number.
Mm.
And they're way more stressed and they start to fail quicker. It almost doesn't matter what the pathology is. The end result is the filtration drops. There's more protein in the urine and the toxins are being backed up into the body. And the dialysis may offset some of it, but in my mind, if I can at least delay the time that before they need dialysis,
Mhm.
correct more than just two lousy risk factors, correct everything I could find. And that means quite often the patient has to pay for the blood work because nobody will listen to me. I'm nobody. I'm not famous. They're not going to listen to me. And they won't even talk to me. They're actually rude about it. Well, that's
Because you're
crazy.
so outspoken, they don't like that.
I'm sorry. I speak the truth, even if it gets me in trouble. I'm sorry. I'm a patient's advocate, not the healthcare system's advocate.
Mhm.
And when I saw my dad go from a GFR of 19 to 61, that changed my life. Because I was just a lipid guy, cardiovascular guy. That was all I did.
Mhm.
And we didn't really pay much attention to kidney disease for the same reason everyone else does it. It doesn't appear with conventional testing until stage 4. 90%. That's uh, when they find out at stage 4. So that means 90% had it and nobody knew it until they were stage 4. The
Mhm.
CDC quoted those statistics. Oh, there's a number of reasons. The doctors are overworked. They don't have time to analyze the blood work. The creatinine looked normal. The lab has a break point of 60 or greater is normal. That's stage 1 and 2. So we ignore 2 stages, and now the creatinine's telling you the stage 1 or 2 and you're 3 or 4.
Hmm.
It's a perfect storm, but the creatinine could help solve the problem if you eliminated it, removed it from the guidelines, and replaced it with cystatin C. They've been trying to do that for at least 15 years. Well, it costs more, $20 instead of $3. So we just wait until they're ready for dialysis. Oh, I'm okay with that.
Mm.
Excuse me? I mean, the level of ignorance is up to here in our system. Well, a lot of the providers know how bad the system is, but the longer they only accept insurance as compensation for their efforts, the more the system's going to boss them around and make them use primitive, ineffective methods to diagnose, that's step one, and treat.
Hmm.
I mean, if Lipitor and Crestor and all the statins shouldn't be used in kidney disease, should never be used with LP(a), should never be used with hyperabsorption. That's a whole nother thing. My brother and I, it's 1 out of 4 people. And they knew this in one of the statin trials, simvastatin. They call it the 4S study. Well, they broke them into quartiles by how much they recycled cholesterol through the intestine.
Mm.
Some people, it's very high. That's 25% of everyone on the planet. When you put them on a statin, you inhibit synthesis at the liver and the absorption goes up. The heart attack and stroke and cardiac death went up 17% higher because of the statin. The placebo group did better. Aortic valve disease, placebo group versus Crestor. Okay, very popular statin. Every doctor loves Crestor. It advanced the aortic calcification and the disease to the point where it was statistically significant. They required aortic valve replacement surgery far more often on the statin than the placebo. How many doctors have bothered to read any of that? It's right there in major publications.
It's still one
And
of the most prescribed drugs out there.
oh,
The
and,
highest between that and I think levothyroxine, so T4, are right there at the top of the list.
it's easy to just prescribe a statin. It's easy to prescribe Synthroid or levothyroxine. Boom, patient's out of there. Next patient. Maybe I'll get home to my family on time tonight if I can go through these encounters quickly. 8 to 12 minutes. How much medicine can you get accomplished in 8 to 12 minutes twice a year?
When
And the
um
compens
when I was growing up in Ireland, I had this one doctor, and he was my doctor right up until I left, except during my 2 pregnancies. He had a female doctor in the clinic, so I would go to see her for my checkups and stuff.
yeah,
But they knew everything about me. They would ask how my family is, how work is, how my mental health is, how am I feeling, and they would just spend all the time I needed, and they would not make me feel like they were trying to rush me out the door. It was more so I knew I have to go and stop talking, but they knew about the whole family. They knew
right.
everything. And remember, they'd always ask about my mental health, which doctors never would do it
Yeah,
now. So, but we're
yeah.
coming up on time and I still have a few more questions. Um, so you did mention sodium, and I know people will be angry if I don't ask about potassium. Potassium's a huge thing in kidney disease, when it comes to definitely conventional medicine. Can you touch on that? And even calcium. I think it would be remiss to not also mention calcium.
Okay, I'll do a quick skinny about those. Those won't take very much time. Potassium, how that first came into my world, once I passed the boards and I worked in open heart surgery, my job was way bigger than most people know. The thoracic surgeons, though, because they had loops on, right?
Mm.
They could only see something as small as my littlest fingernail, this big in their eyes. So they can't look at the monitor. They only know what's going on in the patient's chest. We would warn them or ask them permission to add anesthetic adjuncts to turn the gas on the pump. But one of the things we did before we ever started the actual surgery, they open up the chest, pretty barbaric, and then they cut through the pericardium. It's like a little cellophane-like envelope around the heart. It's got a little viscous fluid around it. Now you got the naked heart beating.
Mm.
Well, it can't operate on it till you stop it from beating. Well, they have cannula, which are tubes. They put one just above the heart, just above the aortic valve on the aorta, the artery, and they had one on the right side of the heart, capturing most of the blood coming into the heart from the veins collected from the body. Well, To stop the heart, they had a tiny cannula. They put it into the ostia. I won't get into technical, but there was a way to get blood just to the heart.
Mm-hmm.
And that cannula would carry a clear fluid that was full of phosphorus, or excuse me, potassium. It's K plus on a periodic table. That stops the heart. It's a muscle relaxant. It's good for like leg cramps. Well, you don't want it to go too high because now you run into some metabolic problems. You also don't want it too low. Well, it's a major risk factor for a number of pathologies. That's when I first understood one thing about potassium. You can stop the heart with it. When it's elevated, it can contribute to arrhythmias and a lot of other problems, or poor contraction of the heart, because it affects every kind of muscle in the body. And certain metabolites and electrolytes have to be watched carefully when you get dialysis. Some go up, some go down. Calcium. Calcium is rather benign. It's probably one of the most important electrolytes, and it has a 2 positive charge. That's why we use it still today to bind phosphorus while it's in the intestine, and now you can't separate them. It's an insoluble metal salt of calcium. But the phosphorus is what causes calcification. Get calcium off your radar. Don't think about calcification. The reason they say calcification is when they do a calcium scan to see if you have calcification, that's what shows up on the imaging. But it's not the problem. The phosphorus is. Well, what else could cause calcification? LP little a. And they never measure it. They're starting to, because now there are 5 drugs coming out that lower it, and they're not even that effective. They remove the little a, and they leave the ApoB particle almost at the same level as it was. The thing is, they misrepresenting the facts. If I have 100 ApoB and 15 of them are LP little a, if I remove the LP little a, the tail, I still have those 15 that are now just plain old ApoB. So it's the same thing with calcium. You're looking at calcium and thinking, oh, I can't do calcium calcification. No, if you take it and it stays in the gut, binded to the phosphorus, it ends up in a bowel movement, not in your blood. And the lower the phosphorus, you'll completely halt calcification or prevent it in the first place. And you need it for normal bodily function. The problem is that even doctors sometimes think, got to lower the calcium, and we don't want to see calcification. Well, guess what? Your bone is made out of calcium and phosphorus, and it's a reservoir. 99% plus is in your bones, no matter how high or low it is in the blood. Well, when there's a metabolic condition like kidney disease, hyperparathyroid, now it's all out of whack. You can get soft bone that leaches out.
And
you can get brittle.
stress. Yeah.
Yeah. Brittle bone, osteomalacia. I mean, those are usually dialysis patients, but it starts progressively with each stage. It's not the calcium you need to control. I'm not going to give them so much Tums to control the phosphorus that the serum level goes above 10.4. And I watch that closely, because if I think we're overdoing it, I back down on the Tums, calcium carbonate. But I'm performing a useful service, keeping the phosphorus out of the body. Now, niacin is pretty cool. Sodium phosphorus receptors are what pull it up into the blood, into the systemic circulation. Niacin suppresses them, downregulates them. So now if I'm binding quite a bit with the Tums and I've got 6 cents worth of niacin, 6 cents is about what a gram costs these days. I
And you're
blunted it
using
getting into
3
the body.
grams or so, right?
Why use 3 grams if it's purely a cardiovascular problem? If they don't really have any cardiovascular markers of significance, and that's not the rule, that's the exception. They just have kidney disease. Well, I got to control the phosphorus. So the studies that are in nephrology journals, there's quite a few these days. One of the first ones, they were using 200 milligrams. That's 1/5, 20% of a gram. And it was effective. The GFR went up. The proteinuria decreased. That was a Japanese study. Owada, OWADA was the author. Really cool. He did a couple studies. And the parathyroid came down. And one of the best markers for damage from long-term phosphorus exposure is fibroblast growth factor 23, FGF23. Niacin is the only thing in research papers that's been shown to lower it. That means suddenly there's less damage from the phosphorus. Duh. The chelators they prescribe in the dialysis unit can't achieve that. And
Mhm.
some of them are very good at binding phosphorus. So how did the niacin work? Probably pleiotropic effects, probably the other 100 things niacin does that most physicians are unaware of. They don't even think kidney disease with niacin. That was, the nephrologist told me the homocysteine goes up. Well, treat the homocysteine. Don't remove the niacin. We just control the phosphorus for a nickel a day. What are you
Mhm.
talking about? Homocysteine, give them some B vitamins, folate, B12, B6, and riboflavin. Now you control the problem. There, spend another nickel. So what? They come in combinations.
Yeah.
You're worried about some excuse for not using niacin. Oh, the uric acid goes up. Well, that's kidney disease. If the filtration goes backwards in the proteinuria and I move them back 1 or 2 stages, which I do all the time, now the uric acid's normal. Quit being myopic. You're looking at one little thing, you're missing the whole picture. If I control the phosphorus, they will not become a dialysis patient. If they are a dialysis patient, they'll at least live longer because phosphorus is poison. And calcium is not poison. I'm trying to control the phosphorus with calcium, which is rather a benign way of doing it. All nephrologists at some point in their career use Tums as the first chelator for a dialysis patient. When you get past 2 grams of elemental calcium, that's the guideline. That hasn't changed. Well, how much Tums is that? Well, 40% of a Tums, which is calcium carbonate, only 40% is the calcium, 60% is the carbonate.
Mhm.
So if I give you 5 grams of Tums, that's 2 grams of calcium and I haven't gone past the limit. I've never used 5 grams, usually a gram or two. And with the niacin, instead of beating them up with too much of one thing, I give them a moderate amount of two. That's good science. That's, rational medical management. And they need the niacin. Everybody needs niacin. It'll extend your life, help you preserve good memory. They use it to reverse fatty liver, even at the cirrhotic stage for this fibrosis. Who knows this stuff? There's actually a patent filing for it, and the FDA gave it the indication, but nobody uses it anymore because there's a smear campaign on niacin. It's been ongoing since 2009, I think. It's
Mhm.
horrible. Well, how come it had a home run for 50 years and now you don't want to use it anymore? Because all those old government studies are wrong. Drug companies come in, mess up 2 studies, and now you won't use it. Cleveland Clinic lied to us about the toxicity of niacin. And of course, all the guys who I admire, a couple of them helped train me, immediately put papers out and discredited that publication. But the problem is when you go to Google and you do a quick search on niacin, all you're going to see is the negative publicity. You
It's
have to
just like
dig a little
aspirin,
harder.
just like what they did to
Yeah.
aspirin as well. So, Stephen, we're going to have to do a part two, and you did tell me where you live, so you can't get out of it. Um, just two final things. Potassium. You said it needs to be watched when someone's on dialysis. If someone is not on dialysis, but they know they have kidney disease or issues, should they be aware of how much potassium? How important do you think that is?
Well, whenever you're looking at anything, potassium, phosphorus, risk factors for kidney disease, things you need to manage, they don't become an issue all of a sudden at stage 4 and stage 5. They've been an issue. It's important to not just be misled by what we call the reference ranges on the labs. Like I said, they say greater than 60 is normal for GFR. No, it's not. Oh, I had a nephrologist tell me when I give a presentation, why would you treat stage 1 or stage 2? You know the answer. So they become stage 3 or 4. And I
Yeah.
looked at him like, is anyone else in the room following this? And
Did everyone hear that?
yeah, well, if you run a cystatin C, you identify every stage 1, 2, 3A, 3B, 4, and 5, dead accurate. And it was so precise when they compared it to a direct GFR. Direct GFR, there's this substance you administer into the circulation, and then you measure how quickly the kidneys clear it. And when the kidneys clear it really slow, your GFR is low. That's a direct measurement. And quite often they do 24-hour urine catch. Forget that. It's labor intensive. Insurance doesn't want to pay for it, blah, blah, blah. So they use creatinine, and it's an estimate. That's why they have a little e, capital G, capital F, capital R. Well, it's still an estimate if you use the statin C, but when they compared them side by side, and they did the direct GFR gold standard, the creatinine was incorrect 57% of the time when they're borderline low GFR.
Mm-hmm.
And what happened is 57% of them had to be staged higher, worse, a whole stage. And when I run it side by side, I always do when I have access to both of them. They never agree. They agree more often when you're already stage 5. Your GFR is 5, you're on dialysis. So what value does it have then? But stage 1 through 4, cystatin C is always showing your GFR is worse, it's lower. Well, why wouldn't you want to know that? That's early warning system. That's better diagnostic power. Why would you use the creatinine? Well, the insurance company says I can't order cystatin C. Order it. Tell the patient to buck up, pay $20.
Mm-hmm.
Problem solved. Well, I can't do that. They depend on their insurance. Wake them up. Do you want to know you're this close to dialysis or this far away? The creatinine is going to tell you this far away, and then suddenly they announce a stage 4. Mm-hmm. And they have not done any diagnosis up to that. They're managing your hypertension, your blood pressure, they're managing your blood sugar, but they missed most of the spokes on the wheel, and that lulls you into a false sense of confidence. Oh, they don't have kidney disease yet. Well, you know what? It's far more prevalent than the statistics even say, because I'm dealing with an African-American church. That's the target population. Not only don't they measure Lp(a), and a third of them have it, they don't use anything but creatinine. These people have 4 times as many African-Americans on dialysis than other races in the United States. That's the problem. We're not diagnosing it, and then we're not treating it correctly, or not as effectively as we could. And if you could buy 4 bottles of supplements on Amazon that'll stop it or reverse it, doesn't that make sense? Mm-hmm. Oh, I can't do that. It's not a prescription. I don't want to hear that crap. Stop protecting the system, the insurance companies and the drug companies. Protect the patient. Mm-hmm. And if you're not familiar with the literature, I'll read it to you. I'll send it to you. If you want me to paraphrase it, I'll just show you the key abstracts. You're well within what we call evidence-based medicine, which is not just funded by drug companies. The best evidence-based medicine is by honest, well-intentioned people that get research grants from the government. They fill out the grant request. It makes sense to the government to give you the money, and then you find some truth. Mm-hmm. You're not going to get a lot of truth with a study funded by a drug company. You're just not.
Well, Stephen, this has been amazing and a lot. And we're going to schedule a part 2. I have so many questions still. I think it's probably best that we do a part 2, because if we kept going, people would just get confused. There's so much out there, but I think this has been very helpful and a lot of information that people can go back, listen, take down notes, and take this to your doctor and say, I want this, I want you to consider this, and even take some things into your own hands. So you can, baking soda, most of us have that in our kitchen. Right. Niacin, you can buy it pretty much anywhere, Walgreens, Shoppers, Boots, wherever you're listening.
One caveat, most people buy the wrong kind.
Okay.
First, there's basically 4 types. One's a placebo. There's a big craze about NAD. Mm-hmm. You know what? You can increase your NAD 400% with 2 to 3 cents worth of niacin. NAD's $30 or $100 a month. It's all mythology. Nobody wants to confront the side effect. The side effect can be handled. Besides, most of the benefit of niacin is in the vasodilatation, which is a side effect that's temporary. But you still get the vasodilatation. The first few days you'll get red, you get a hot flash. Not everybody's the same. Mild, some are severe. Somebody
I get
like me
so itchy everywhere, and I can't stop scratching.
Alka-Seltzer and 3 tablespoons of applesauce, and only bail it out when it occurs. If you actually take it every day, it'll diminish. It's less severe and less frequent within 2 weeks to a month. That's important to know. And don't mess around with low flush. long-acting, time release, sustained release. Those are toxic. They're not as toxic as a statin. If I took Lipitor, Crestor, and made a 24-hour release, it would kill you within a day or two.
Mm-hmm.
Niacin, it's a reversible toxicity of the liver, but it only occurred with sustained release. Well, that's a 12 to 24-hour release, and there's no liability to a supplement manufacturer.
Does that
And it's right
include
there.
the non-flush ones, the ones that
No,
will specifically?
non-flush is a placebo. It's essentially a form of
So
NAD.
there's no point in using that.
Yeah, nicotinamide, niacinamide. You get some NAD, but you're going to pay a lot more for it. Those cost more on the shelf,
Mm.
not even behind the pharmacy counter, but on the shelf where you can just walk up and grab it next to the sustained release. Well, the sustained release is potentially toxic. You can't give that much, and you can't give it more than once a day. And then, of course, most of what's around there is no flush
Mm-hmm.
no flush niacin,
Mm-hmm.
worthless. And that's the um, hexanicotinate inositol. The inositol is surrounded by 6 niacin molecules, and it won't let go of it. So the nicotinic acid, which is niacin, never shows significant levels in the bloodstream. And the rest of them are all forms of nicotinamide, niacinamide. They don't do anything. They're just an expensive form of NAD. Well, the extended release is fairly safe. But if you have a hot flash, it'll be an extended hot flash. It can go on for an hour or more. Immediate release peaks rapidly and disappears rapidly. Within an hour, it's all
I
gone.
think mine was within 12 minutes, it peaked and then started to dissipate.
Must have been the right kind, immediate release. And all you got to do is have an Alka-Seltzer with you. And remember to take niacin with you any meal outside of the home, a vacation, one meal at a restaurant nearby, a weekend away. Make sure you got enough niacin to get you back home and one Alka-Seltzer. You get a bad hot flash. Let's face it, you're going out to dinner, you're probably going to have some wine. I'm gonna. that's the one carb I allow myself every day. I need a glass of wine. Well, that'll provoke it. Alcohol, spicy food, hot beverages like coffee,
All the good stuff.
a hot shower, and sex. They all provoke it. The only one that I've never heard complained about was the last one. And not to get off color, but if I got a male patient, they're
You're
comparatively
weighing the
young.
pros and the cons.
Well, I have to remind them before Viagra and Cialis,
It was nice and
it's in the literature. They use niacin and it worked. Well, it's the same guy with his red baseball hat staring at me, acting, uninterested. So one thing you remember.
Mhm.
And he takes it home, and I know what he's doing with it. But I'm trying to keep him from getting heart disease, and he's more worried about it, his interaction with his significant other. Well, it does work. And if that's all that you're interested in, so I can fix everything else that's wrong in your body,
So be
go
it.
right ahead.
Yeah.
Go right ahead. It's just, all I want him to get from it is the niacin's good for you. Don't throw it out just because you had a hot flash. Be a grown up. And most of my older patients go to church, so I tell them, you know why God made the hot flash with niacin? Well, he knew it was a miracle drug, and he wanted you to step up, being a grown up, not a big baby. So he's testing your faith. It's
That's a
temporary.
good one. I'm going to
It's
use that
temporary.
from now on. God is testing your faith. Can you stick with this or not?
Yeah. And
But
then,
I,
he was a busy guy, still is, but in the beginning, it took him a week to make the whole universe, planet Earth, everything on it, including us. I figured 6 days into it, Saturday night, he was exhausted. I mean, God's got emotions, he flooded the earth and then he brought us back. I mean, he's a lot like humans, only he's perfect and he lives forever, but he has emotions. Well, he was probably tired Saturday night. He had a lot to do that week. And nobody's around at that point to pat him on the back
yeah,
when he invented niacin. And it was late Saturday night. He went, wow, how do I reward myself? Well, he decided to
a
take a
glass
day
of
of
wine.
rest till the end of time. So he took Sunday off since it was the next day, or Sabbath, which is Friday, I guess. But the point is that it's that big of a deal. There's a lot of natural stuff that has a therapeutic benefit. Niacin is absolutely required for the function of 400 enzymes in the body. There's at least 380 genes that won't function normally without niacin. And Cleveland Clinic was trying to tell you it's poison. Well, let's have a pellagra epidemic. That sounds good to me. That's where they first developed synthesis of niacin as a supplement. It was a nutritional deficiency, mainly in poor people who had bad nutritional habits. Pellagra is horrible. You'll eventually die from it. And now they're trying to tell us not to take any based on a metabolite. It's insane. There's a lot of bad information out there. That gets all the attention. NBC, ABC, all the news feeds went with it. Because, it's like they say in the old newspaper industry before there was TV. If it bleeds, it leads. That's what you put on the front page. Bad news on niacin. Ooh, let's scare everybody. I have to deal with this every damn day because that's the first thing a patient tells me. Oh, I heard it's dangerous. Oh, I heard it really doesn't work.
Again, the same with aspirin, same old story. So, Stephen, if I'm correct, you either emailed me or you have it on your website. You have a list of steps and guidelines for niacin. So, if people
Sure.
want that, I'll give it to them. Just put it in the comments or
Okay.
email me and I'll give it to them. We'll come back for part two. Clearly, we're both
Okay.
passionate, lots to talk about.
I'm overly passionate and I talk too much, but yeah, I like to think that, yeah, there's some useful
It's
words
making
here
a
and there.
difference. Yeah.
Yeah. If I get 2 or 3 points across, I've done my job, even though it took forever to tell you. But I have to paint pictures with words because most of my encounters are over the phone and doctors don't have a lot of time. So I get them on the phone. They're probably not going to read the literature, but they trust me enough to call me.
Yeah.
Say, it's like this, it's like that. Don't use it here, but definitely use it here. Here's how you use it. They complain about the hot flash, make sure they got an Alka-Seltzer and 3 tablespoons of applesauce ready at the first dose,
Mhm.
the very first time they take it. Now, if they're on the mild spectrum, no issue. Moderate, well, maybe they'll need it. But if they have a severe hot flash, the first thought is, this is crazy. I'm not taking my niacin.
It's not that bad though.
Yeah, show them how to get rid of it. Then they have control. It's like I tell a patient, you ever been to a circus when that was popular? I'm 70. I went to a circus
I've been
when I
to
was a little kid.
circuses. Yeah.
Well, they got this cage full of lions and tigers, and then this guy, this human being, walks in. He's got leather boots. Well, usually they have a pistol, a whip, and a chair to control these wild animals. Well, if he didn't have the pistol, the whip, and the chair and walked into the cage, that's kind of stupid because those are wild animals.
Mhm.
Maybe they were defanged or had their nails clipped, but they're
Declawed.
still going to hurt you. Well, taking niacin without being prepared for the hot flash is like the lion tamer without any equipment.
Mhm.
You might not have a problem. You're done. Just remember someday you might have a problem and have an Alka-Seltzer in your purse or in your wallet. Have it stuck in the back. And I have patients I haven't talked to in years, and they call me up to tell me their Alka-Seltzer story. And I go, wait, I said, I can save you time. Were you celebrating? Yeah. Was it like a wedding? Somebody graduated? Yeah. New Year's Eve? Yeah. And there was alcohol. How'd you know? That's number one on the list.
Mhm.
Normally you don't drink that much, but now you got an excuse to have a few extra rounds with the boys. All the women sit together, the men stand in a circle and drink too much. Well, your friends are going to think you're having a stroke or a heart attack or, we're out in the sun too long. Just slip away quietly, say, I'm going to the men's room, get a glass of water, or these days, a bottle of water,
Mhm.
you know,
Take some
remove a
Alka-Seltzer.
little bit of the water, put the Alka-Seltzer in there and sip it. You're sitting in the stall, not because you needed to have a bowel movement, because you don't want to embarrass or concern everyone around you, including yourself. And then sip on that. Before you get half of that Alka-Seltzer down, the hot flash is gone. And I tell them, and now you deserve a reward for handling it. Go out and have another drink. You won't have another hot flash. Because as long as that Alka-Seltzer is on board, you're bulletproof for at least an hour or two.
Well, Stephen, I'll share that. We'll definitely have to discuss alcohol more in our next conversation. Thank you for your time today. You sent me so much information. I'll
I know,
put
too much.
links. People know they can email me or reach out to me. I respond to most of the comments and everything, and I'll send them. So thank you for
Great.
your time. This has been very entertaining.
Well, I used to be an entertainer. I guess I still am. What was I going to say?